So yeah, let's start. Welcome, dear participants, dear panelists. Welcome to our webinar here on GLOHRA meets the Alliance for Health Policy and Systems Research, hosted by WHO. I'm Nora Anton, I'm the Managing Director of the GLOHRA Secretariat. And again, we're very happy to host this webinar on health policy and systems research in Germany. Thank you so much to colleagues here from GLOHRA, from different institutions, from the University of Bielefeld and the Alliance for Health Policy and Systems Research for moving forward this initiative. As I said, welcome, dear participants. And with this, I would already like to hand over to our moderator for today, Professor Joanna Hanefeld, who's the acting vice president of the Robert Koch Institute and a very strong advocate for building the field of health policy and systems research in Germany. Over to you, Joanna.
Yeah, thank you very much, Nora, and a very warm welcome also from my side to our panelists and to everyone who's joining today. I've really been looking forward to today's webinar. Nora already introduced it. It is about the German Global Health Research Alliance, GLOHRA, and we call it GLOHRA meets health policy and systems research. So we'll have a fantastic discussion today. As mentioned, my name is Joanna Hanefeld. I'm acting vice president of the Robert Koch Institute, Germany's National Public Health Institute, and also the head of its Center for International Health Protection. And I'm also an outgoing steering committee member of GLOHRA. So it's really my great pleasure to be moderating this webinar today, where we will be looking at different initiatives in the field of health policy and systems research and connecting these, what's going on in Germany, the different initiatives, how these provide further entry points to strengthening the field in Germany, and very crucially, to further collaboration internationally. And we're absolutely delighted to be explicitly learning from the Alliance for Health Policy and Systems Research, which in many ways has built this field worldwide. And we'll be hearing a bit more about their work in a moment. So for me, as Nora mentioned personally, this is also a real milestone, bringing together sort of initiatives that I have worked on for many years and I'm very enthusiastic about. And I think we can contribute. We're already contributing in Germany, but we can contribute even further. The seminar is organized by GLOHRA, but it's organized in collaboration with the Department of Population Medicine and Health Services Research at the School of Public Health at Bielefeld University. And Bielefeld is one of those centers in Germany, together with the University of Heidelberg and some nascent steps also at the Charité Medical School here in Berlin, where the field is already somewhat established, and we'll be hearing from researchers on this over the coming hour and a half. So again, we've got a very interactive program, so we do invite you not just to listen, but also to actively participate and contribute. We'll be hearing from the director of the Alliance for Health Policy and Systems Research, which is anchored at WHO, Dr. Kumanan Rasanathan. And then we've got 4 presentations from actors with very different positionality in the field who work in Germany. I'll be introducing each of these in turn. And then we have time for a Q&A afterwards. So as we're listening to the presentations, if you do feel a question coming on, start typing that into the Q&A or the chat function. And I'll be reading that out. We'll have a chance for an interaction that way with the speakers. And before we wrap up today, we'll have a short panel discussion on how to advance this field and how to move forward here in Germany. So I really look forward to discussing and learning from all of you over the next hour and a half. And with that, it's already my great pleasure to really introduce Kumanan, who is a leader in this field. So he's a public health physician, he's a health policy researcher, and he is now the director of the Health Policy and Systems of the Alliance for Health Policy and Systems Research, which is hosted at or anchored at WHO. And Kumanan, please, over to you.
Well, thanks so much, Joanna, and thank you. Hello, everyone. Guten Tag. And thank you to our GLOHRA colleagues, Nora and Leah and others. And thank you to our Bielefeld and Heidelberg colleagues for making this happen. We're just so delighted that we can join with you today to talk about health policy and system research, understand what Germany is doing in this area, and think about how we can all contribute more impact from field which we're all so passionate about. And Joanna was quite modest. She didn't mention that she herself, of course, is a global leader in health policy and systems research. So I'll try to share my slides. And great. And Joanna, hopefully you can see that.
That's
and
perfect.
You can't.
Yes.
So
No, we can.
today,
That's perfect. Yeah.
great. So today, really, I'm just going to briefly speak about, well, what is health policy and systems research, review what has happened over the last 30 years of the field that it's existed, and then talk a little bit about how we feel that research can contribute more to the challenging current situation, including introducing our new strategy. And so what is health policy and systems research? We're well aware that it's not something that's easy to understand for many people, but essentially health policy and systems research is work on health policy and health systems, which aims to address the no-do gap. So it's not discovery science or biomedical research, which is trying to create new vaccines or new medicines. It's really saying, well, why don't we deliver the policies and interventions which we already know work, but which still don't reach so many people? So why do hundreds of thousands of children still die a year from pneumonia when we know how to diagnose pneumonia and we could treat most of these pneumonias with amoxicillin that costs less than $1? So it's really, how do we ensure health equity? And how do we organize ourselves as societies to achieve collective health goals, address this no-do gap, ensure that policies and interventions are delivered to benefit everyone, considering linkages, interrelationships, interactions within the health system and between health systems and the social determinants of health, and how actors, ideas, interests, institutions, and it's multidisciplinary. It's not just epidemiology, which is the alpha science of public health, but it also takes advantage of economics, of sociology, anthropology, political science, organizational theory, law, psychology. And the schematic on the right shows the relationship of health policy and health systems research, which are linked but distinct, and their relationship to other types of public health research. And health services research, which some of you may be aware of, we see as a subset of health systems research. Over the last 30 years, the Alliance was thought about in the mid-90s and started in 1999. Leaders in the field like Jonas Sturkey, Joran Thompson, Ann Mills, Julio Frank came together in the 1990s and said, we need an international institution to support health policy and systems research, to help nurture it. And over the last 30 years, the Alliance, but the community, has had a lot of achievements. The field is now mature. Health Systems Global, which is our sister organization, which will organize the Global Symposium in Nagasaki in November, where we hope to see many of you. It says that it now has members in 125 countries. So people in 125 countries at least are saying they do health policy and systems research. There is this community. There is a symposium that draws up to 2,000 people every 2 years. There's a society, Health Systems Global. There's clear methods, approaches that have been documented, and this research has had documented impact on policy and implementation. There's capacity, there's methods such as embedded implementation research, systems thinking, and the field has gone beyond health system building blocks to consider the broader contributors to health beyond the health sector. But there are also gaps, as we were just discussing before this session started. Most people don't know what health policy and systems research is. They don't understand how it can be useful. It's very poorly funded compared to other types of health research. In most low and middle income countries, funding is almost exclusively driven from other, external sources. And where we have seen systems failures very visibly, such as during the West Africa Ebola epidemic, most recently during COVID-19, that hasn't led to major investments in the field or even necessarily in health systems. And we don't necessarily have the indicators to show our impact. So in this time of multiple crises, of climate crisis, of increasing conflicts, increasing polarization, increasing inequality, of COVID and other emerging infectious diseases, of cost of living crises, which are tearing the world apart, which means we're far off track to the Sustainable Development Goals and other global health targets. The challenge has to be to demonstrate how health policy and systems research can be a contributor to putting us back on track, to managing the crises of today and preventing the crises of tomorrow. And we genuinely believe this, that this has to be the mission of health policy and systems research. And then when we talk about it, it can sometimes seem very conceptual. We have our frameworks, but we need to keep in mind that the people we're trying to assist with this work that we're contributing to in their ability to realize their right to health and health equity are people like healthcare workers, such as this female community health volunteer from Humla province in Nepal, above 3,000 meters, one of the most impressive cadres of health workers on the planet, which I used to work with almost a decade ago, or even in my home village of Karanaga, which is where I'm from originally, in Sri Lanka. I'm a New Zealander as well. How does health policy and systems research, how does our work contribute to their lives? Does it make a difference? And so I think we can do three things on our research. Firstly, our research has to be more focused on impact. It needs to be more timely. It needs to be aligned with budget cycles, with policy cycles. Policymakers and implementers, when they have questions and problems, they're not necessarily waiting 2.5 years for us to publish a paper. Now, we cannot always guarantee our research has impact, but we can create the conditions to maximize our chance of having impact. We can genuinely realize the potential of our interdisciplinarity. Even though we use all these fields, sometimes we're still very siloed ourselves. And we can harness digitalization, not just monitor whether digitalization leads to good or bad in health, but also think about how digitalization can make our research process more efficient, more accessible, and less costly. And particularly in low and middle income countries, how can we do more health policy and systems research with less resources or the same resources by using AI, by using digitalization? For example, in the way we do scoping reviews or systematic reviews. So to finish, I'd just like to, this is our new strategy, and this is how we're thinking about having more impact. Our strategy is called Aiming for Impact. We have three main shifts: more of a focus on impact, greater engagement with the knowledge ecosystems in countries and their priorities and context, because that's where change happens, including their institutions, and building new partnerships. We've identified 5 priority areas. And the reason we've done this, they're all linked, is because often people don't know what health policy and systems research is or what the Alliance does. So by naming these 5 areas, they can see where we might be of use. And those 5 areas are traditional work on health systems. We're calling it universal health coverage through primary healthcare, the digital transformation of health systems, prevention of non-communicable diseases, the role of health systems in the climate crisis, and a systems approach to emergency preparedness and response. We'll still do the 3 things we've always done. We generate, so we support research in low and middle income countries, we fund it, but we provide technical support, we strengthen capacities in countries, although we have more of an institutional focus now, and we advocate at the global and national level for how health policy and systems research is useful, a little bit what I'm doing now, and also for more funding. We have new programs of work in all of those 5 areas, and here are some areas that we're currently launching. The third one on national public health agencies. We're very pleased that Germany and RKI is involved, looking at Germany's experience around governance of national public health agencies post-COVID. We're doing that with Germany and 12 other countries. We met in Singapore a couple of months ago. So here is, if you're interested more on our strategy, you can download it from this QR code or this link. But in summary, that's just an introduction. We feel that health policy and systems research is an essential discipline and field that can contribute much more to getting the world back on track towards the Sustainable Development Goals. But to do that, we perhaps need to do our work differently, and we think Germany can contribute so much. So look forward to hearing more from the colleagues. So thank you, and Dankeschön, and back to you, Joanna.
Thank you so much, Kumanan, and fantastic to point out not just what the field is, but really where we need to push harder and where we need to advance it. So Kumanan has already mentioned that one of the areas that is obviously critical for a field which is still sort of relatively, which is large and has grown massively, has matured to an extent, but does require continued funding. So in terms of the presentations we have from Germany, I'm absolutely delighted to be introducing our first speaker, Dr. Lisa Hoffmann, who's from the German Federal Ministry for Economic Cooperation and Development, which has supported the field from a German perspective in global health and in international development. Lisa, I hand the floor over to you.
Thank you very much. Thank you very much, Johanna and Nora and GLOHRA, and also thank you very much, Kumanan and all the other colleagues for inviting me today. Let me share my slides with you so I can start right away. Okay, does it work?
It's great. It's not in now it's in presentation mode. Fantastic. Thank you so much.
Perfect. Thank you. Yes, Johanna, so thank you for already introducing me. My name is Lisa Hoffmann, and I work for the Ministry of Economic Cooperation and Development, and specifically in the Division on Global Health Policy and Financing. Let me maybe start by just saying we for sure need the insights on health policy and systems research, right? For various reasons, and I will touch upon some of them in the end, but so I'm actually very happy that I've been invited to this meeting today, because it is very crucial that we actually also as policymakers get the evidence of research to design then projects that have impact. I decided to structure my short input in actually 3 sections to first give you a little overview on the priorities of BMZ in this period. Then secondly, by pointing out some of the core topics, including health and our priorities within health, and then by giving you some more concrete examples on what we do and my thoughts about potentials on how we can make use of the knowledge that you actually generate. Okay, so first of all, as many of you might know or might not know, we actually have 4 overarching large political priority themes at the BMZ in this legislative period. And those are feminist development policy, climate action and just transition, then 3rd, leave no one behind, so poverty, hunger and inequality, and then 4th, global health and pandemic prevention. And why do I actually say that? It means that health is not just important like many other topics that we deal with, and many topics are of course important in the area of development cooperation, but it is even one of 4 political priorities. So this means that actually it is really important to us to focus on global health and pandemic prevention. Then secondly, maybe just to show you a little bit on where we work, if you are not aware of how the BMZ is structured. So we work with different partner countries in different formats. We have bilateral partners, global partners, and so-called Nexus and peace partners. And altogether, it's currently 65 partner countries that we work with. But of course, we work both multilaterally and also bilaterally. And I will give you some examples on that later on in the different regions of the world. So now, having shown you the priorities of the BMZ, we also have so-called core topics. And this kind of means that we have a strategy on the specific topic to specify what our goals are and how we want to reach them. And you don't have to read through them all. They are also available online, but the very last of them is actually the core topic on health that is relevant for us and for today. It's on health, social security, and population dynamics. And this strategy has been published, I think, in summer last year, so September 2023. So it's still quite recent, and there we really actually spell out on what we want to focus on and how we want to reach that. So within the core topic, we have several subtopics, and the first one is actually health, pandemics, and One Health, and their strengthening health system is the first action that we want to do. So it's super important for us that it's anchored there, because it means that we have kind of developed the ground on where we act. We also want to focus on local vaccine and we already do on local vaccine and pharmaceutical production and logistics. We want to improve pandemic preparedness and resilience, and also anchor the One Health approach and further developing the global health architecture. Then the second topic is more on social protection, which is of course also very related to today's talk. And the third one is on population dynamics and sexual and reproductive health and rights. You might already seen that we, of course, are very aware that focusing on health also means that it makes sense to also combine those insights with our other topics, such as feminist development cooperation. So there are, of course, many interlinkages. So maybe just to give you some more examples and insights on health system strengthening, which is, a main priority for us, and also universal health coverage through primary health care. So as you can see, actually, I just thought when I heard the talk of Kumanan, our goals are actually very similar. So it just makes sense that we also work together and share insights and so on. So what we want to do is we want to support our partner countries to build resilient health systems, including their sustainable financing. So for example, questions like how to generate enough domestic resources for health and so on are questions that we deal with. As I also mentioned before, we work both through bilateral development cooperation, but also through multilateral development cooperation. And this is important because sometimes I think that maybe it's not very present that we actually do, especially in the sector of health, a lot via multilateral projects. So just to give you some examples first of our bilateral development cooperation. So we actually worked on a climate strategy in Togo to prepare health systems, to better prepare them of the consequences from climate change. There are several projects to strengthen vaccine and pharmaceutical production, for example, in Senegal. Then we work within providing for health, a network which focuses very much on health financing. And then we also work on, for example, a very large project actually in India, where we focus on health insurances. So in bilateral development cooperation, I actually see a great potential for HPSR or for the insights of HPSR to use them for the programming. And I mean, we do that already, right? That of course, when we design new projects, we will use existing evidence also from research, but also from past experiences to make sure that our projects also have positive impact. But I also see that there could be the potential for an even closer collaboration. Then secondly, we work a lot via multilateral development cooperation. So for example, within Gavi and the Global Fund, but also G7, G20. So there I see that we can use the insights of HPSR to inform strategic decision. And then lastly, I just thought a little bit about what we need in a best case, of course. So, I mean, it's always interesting for us to learn more also about the generalizability of results. I mean, of course, I know that it's not always easy, right, to see if results can travel, but then it's interesting for us under what conditions could they potentially travel. Then secondly, learning from best practices where things work, but also learning from cases where things do not work. And lastly, science-based communication. So for example, like with GLOHRA, where GLOHRA published policy briefs, things like that are very useful for us. And with this, I want to end, and I thank you for your attention.
Fantastic. Thank you so much, Lisa. It's great to have an ally in our Ministry for Economic Development and for Economic Collaboration and Development. And thank you also for being very much on time with the talk. Great. So now it's my pleasure to move to one of the sort of leading German health policy and systems researchers internationally, Professor Kaivan Besorgmer from the University of Bielefeld. And Kaivan has really applied health policy and systems research to different intersecting crises. And he's particularly known perhaps in Germany and has published widely on the area of migration and taking an HPSR lens to the issue of migration. So Kaivan, please, over to you.
Thank you, Johanna, for the very kind introduction. And I'm very glad as an outgoing steering committee member that this event has materialized. Let me share my presentation with you, and I hope you can see the slides now.
We can. It's not in presentation mode yet. Super, great.
Okay, so can you see the presentation, or do you see the...
We see the presenter view, so we see two slides at the same time.
Okay, sorry. Apologies.
It's the same, but I think we are happy. I think even like this, it works.
Okay.
Let's go like this. Let's go like this.
Yeah,
If you're
okay. I'm not sure why this happened, but again, let's
Don't
start.
worry, don't worry. We
Okay,
see it
thanks.
well.
So let me start with the presentation in the sense that I want to give you a nutshell overview of the added value of applying health policy and systems research to migration studies. And as we just heard, our world is plagued by intersecting crises, or the notion of polycrisis, as pointed out by Kyumanan, in the sense that we have multiple forms of crisis that intersect and mutually reinforce each other and partly converge. So we have multiple forms and repeated forms of economic crises. We have the ongoing crisis of multilateralism and a governance crisis. We have the omnipresent effects and results of a climate crisis going on. And we live in a world where basically ongoing threat of pandemics that has materialized more recently in the COVID-19 pandemic. And we live in a millennium that has the highest numbers of armed conflicts, not only since the Russian war against Ukraine and the recent escalation, but also without these more prominent conflicts, we have more than 50 conflicts going on in the world. And all these conflicts are also related, or all these crises are also related to or result in migration, mobility, and displacement. So the human mobility and human migration is strongly associated with multiple forms of crises. And in the last few years, we have been dealing with from a health system perspectives with the issue of migration. We have been analyzing how health systems respond to large-scale migration and diversity. We have been analyzing from these perspectives how and why do systems and regions perform better than others, and have tried to explore how the response can be improved by looking at the multiple elements of the health systems and their interrelations in order to understand how the response can be improved in terms of improved health of displaced or migrant populations, in the sense of better responsiveness and improved efficiency. In this respect, we have actually produced a lot of results that have been looking at health policy and systems perspective, looking at the political economy of different systems where they converge. For example, the immigration system in multiple countries with the health systems and how conflicts emerge. We have looked at the financing systems and how they relate with normative issues. And we have looked at the role of leadership and governance in the context of service delivery and what it makes with the effect on accessibility and quality. And these results have been, on the one hand, on the academic part, but also, as we just heard, attempted to feed them into impact in the sense of providing results that are of relevance to policymakers and decision makers, and to inform, for example, as you can see here, the practice and the policy in practice as a response to large-scale migration in the European region. More recently, we have been, I just realized you just see the slides in lagged form, so that's a bit of a unfortunate situation. So I think this is better now. So more recently, we have been realizing that linked to these intersecting crises, there is an element, a phenomenon that has been always there, that is also linked to the notion and issue of the health system, which is the phenomenon of uncertainty. It is most oftenly understood and realized as a lack of knowledge or a situation where we cannot assign probabilities to certain outcomes. And it is not an objective static state, but it's the dynamic state, and can also be understood actually as a subjective perception or an affective condition of actors, of agents, or also of organizations. It can be understood as a property of relations or also a mode of action. And moreover, and this is very insightful as well, that uncertainty can have material, physical, and biological correlates. We have been dealing with this issue the last 2 years in certain initiatives of the university in an interdisciplinary approach, and this has been recently also materialized in a graduate school of health policy and systems in uncertainties, where we try to understand better the role of how systems actually make use of or also navigate the notion. And this is a heuristic frame and approach that we have been developing in some of our projects that are, it's a very much of a working work in progress result, where we try to understand how different forms of crises create or build upon uncertainty, and how migration itself as a phenomenon is interlinked to multiple forms of uncertainty during the process of migration, and how actually the processing of individuals, organizations, and systems result in outcomes or in terms of behavior that then at the end impact health system accessibility, continuity, and quality of care. So an attempt to bring in the notion of uncertainty into the pathway from crises to health system outcomes. And I want to give maybe one example or two examples on our recent research in these areas. So in one area, we looked at the early crisis response to COVID-19 pandemic, where we looked at the local authorities' responses and cooperation structures in response to the pandemic in the early few weeks, looking into 3 different areas: information, communication, contact tracing, and quarantine and isolation. And we really use different methods to dive into the relations between different actors. And I'm not going deeper into that, and just giving you a nutshell insight of that. We found that, for example, the uncertainty of the decision makers in absence of clear-cut structures for cooperation led to a sort of randomness that then translated into securitization tendencies. The second example that I want to give in a very short time is in terms of timeliness, that we conducted, for example, a health system impact assessment that will be forthcoming, looking at the impact of the large-scale displacement from Ukraine on health systems in refugee-receiving countries in WHO, where we looked at 7 countries, looking at the complex migration dynamics caused by the war, but also which intersected with the COVID-19 pandemic in 2022 and the energy crisis, leading also into now a more protracted conflict. And where we identified how the systems actually met the higher need for healthcare and translated into ongoing adaptations, but also where our approach helped us to identify transformative policies in multiple health system domains that are required to mitigate not only the uncertainty, but also support the ongoing adaptation and enhance the resilience. To close my presentation, so the added value of health systems and policy research in the field of migration has provided us insights into intangible elements of the responses to migration. It has shown us insights into different relations between health system elements going beyond structures and written policies, and has provided us also insights into the production of othering, that is, understanding how system actors and agents manufacture and produce inclusion and exclusion, but also shedded light on required adaptations and transformations to overcome performance gaps and sustain or enhance system functions. And overall, it avoided that we treat migration as an overarching phenomenon, as something that is exceptional or as singularity through the application of a systems perspective. Thank you for the attention, and I'm looking forward for the discussion.
Thank you so much, Kevin, and really interesting insights into how health policy and systems research as a lens helps address this issue of uncertainty. And certainly, just as a comment, the work done on migration very much addressed that no-do gap, right, in the German context. So very impactful research conducted by your group and by yourself. So we go on in our program, and it's my great pleasure now to introduce Professor Manuela de Allegri, who's the sort of other giant in health policy and systems research in Germany. She's a health economist. She's worked with multiple partners, mainly on low and middle income countries, on understanding health financing, different approaches to health financing. Manuela, I can already see your slide in presenter mode, so over to you.
Thank you very much for having me here today. I'm delighted to be with all of you, and thank you very much for a very kind introduction, too kind actually. So it's a pleasure for me to be with you today and to look at how we have used in my team, I would like to say, because I obviously do not do this research alone. We have used the health system and health policy and system lens to do research in health financing. And let me start by briefly explaining where we situate health financing within the health system, and more specifically, the three health financing functions of raising revenues, pooling and purchasing, as well as defining health benefits, how they're situated at the core, so to say, in relation to creating resources, obviously the key function of a health system governance and service delivery. But ultimately, the objective is always that of achieving universal health coverage. So we're always looking at expanding access to quality healthcare services while ensuring financial protection, with the objective, as many of my colleagues before have said before, of leaving no one behind. And as health financing people, ultimately, we introduce policy reforms to modify the way in which we raise and pool resources and buy health services. So we look at ways in which this can be done in order to achieve universal coverage. As researchers, we come in as health policy and system researchers working in health financing. Our task, so to say, is to produce research that informs the development of policy choices, monitors their implementation, and evaluates their impact within this space. And what I try to do with you today is just to provide some examples of how we have done it. And I will look at three different examples spanning completely different experiences. The first illustration looks at Burkina Faso. Burkina Faso is a country that is particularly dear to me. I call it my second house. My second home is the place actually where I wrote my doctoral dissertation on something different, health insurance and not user fee removal. But Burkina Faso has a long history of trying to remove user charges at point of use. And I will look specifically at how we compared the partial removal to the complete removal of user charges for maternal care. And we proved that the complete removal of user charges, so moving from an 80% removal to 100% removal, actually increased utilization substantially. That complete removal really played a very big role for women and really could further improve utilization of health services. And having done that, played a very big role for policy, because we could actually provide evidence to inform the government, and the government, based on this evidence as well as other evidence that we generated and other teams also generated, actually passed a policy in 2016 to decide for the full removal nationwide. And we're currently working with the government further to create further evidence. So that's just an example of how research is really used to generate evidence that then translates into policy. Another example, and I'm taking you to a completely different context here, we're working with colleagues. More specifically, my two co-PIs are Professor Andreas Landman from the FNU in Erlangen, University of Erlangen, and Zahid Khan from KMU in Pakistan, and with funding from the KfW, the BMZ, so from the German Development Bank, so to say, and ultimately from the BMZ, we are accompanying the launch and implementation of the first outpatient scheme in Pakistan. So there is this ambition to move beyond social health protection that's just covering tertiary care, secondary and tertiary care, into the primary care. And we're working through an integrated knowledge translation approach. What does this mean? This means that from the very beginning, the research questions are set in conversation with policymakers, implementers, healthcare providers, and civil society, in such a way that the research program is really set in conjunction with the wider community. And what are some of the products we have produced until now? We have looked at the needs of the ultra poor. Sorry, I forgot to mention, this is a scheme that actually targets specifically the ultra poor. We've looked at beneficiary preferences. We've looked at the healthcare provider network and the preparedness to actually meet this, what the scheme will be. And we've actually conducted a policy analysis. And how do we communicate these findings? Not just through academic publications, we have in-person workshops, we have policy briefs, we have online workshops, because of course, it's impossible to always travel whenever there is need to communicate a policy finding. And we also have a blog. So we monthly put on the blog any news that comes out of the consortium, just to show like creativeness that also needs to be there in the communication or in the field around health policy and systems research. And what I would like to underline, the particularity of this project is also the explicit inclusion of an element of health policy analysis. So while we're producing evidence on the impact of the scheme, we're at the same time explicitly analyzing the policy dialogue that takes place to sustain the implementation of the scheme. Last but not least, I represent GLOHRA here. I'm actually part of the GLOHRA steering committee, but I've actually also worked, before I think I took official office as GLOHRA member, directly with the Alliance for Health Policy and Systems Research. And I would like to reflect a little bit on this experience. This was actually a research program supported by the Alliance. So the Alliance supported a research program in 7 different countries, and you see the list on the slide, to examine existing initiatives aimed at increasing the accountability of existing health insurance schemes. So we know that very often health insurance, social protection programs take place all over the globe, but people are not sufficiently well informed about their benefits. And people don't know how to make use of the benefits they're entitled to. And therefore, the Alliance had the idea to support a research program that would promote studies into looking at how these initiatives work. And they looked for collaboration with researchers, and I was the researcher serving as a collaborator, and a person in the WHO Health Financing Unit, my colleague, Dr. Inke Matawa. And we really worked together under the leadership of my colleague at the Alliance, Dr. Zubin Shroff, and we worked with these 7 countries to advance this research program. So we developed together with these countries a conceptual framework. We facilitated workshops, dialogue, so that there would be a common research agenda, but carried out in the different programs. You see here the link to the publications. There have been a number of publications out of this research program, and we're currently working to synthesize the lessons learned across the different countries in a single common publication. And on this positive experience, I would like to say, which brings together already in a way the 2 communities, I say thank you for your attention.
Thank you, Manuela. Thank you for a really great presentation, also outlining the different channels of communication that you use to create that impact, right? Not just the research and the methods you use applied to your field of health financing, but also the different formats in which you engage to create that impact. So now we're going to move to a partner perspective, and it's my great pleasure to introduce Dr. Sandul Yasuband from the Indian Institute of Public Health in Gujarat, who has taken health policy and systems research to another field, One Health, and its complexities. So he's going to present on the experiences from Western India, learnings on a whole systems approach and translating the One Health into action in his context. Please, Sandul, the floor is yours.
Yeah, thank you very much, Johannes, and thanks. It's my pleasure to be here. I think my slides are visible and I'm well audible. So it's my great pleasure, and to also my previous colleagues and the experts has already talked about how the HSPR field has been applied and the core concepts. I would hence like to take you further on implementing the One Health concept from the one whole systems approach through a project which is well honored to receive this funding from GLOHRA, with funded from the BMZ and GIZ, is called co-creating the One Health workforce through health system strengthening in Western India. Talked about OSHIN, so I kindly acknowledge the German partners, the University of Bonn, and some supported partners within the India. The prime objective to have all of us on floor the same ground is that we know the One Health is something which more of transdisciplinary and connecting between the human, animal, and environment. But when it comes to the One Health system, so one layer of complexity added to it. So that means when we deal with the One Health implementation, when we talk about the human health system, animal health system, and the environment, which not only excludes the agriculture system, forest and wildlife, and so on, the water and all, so that the complexity multifolds while implementing the One Health into the real practice. Just to give an overview about how it works in the India, taking the examples from the what we have already implemented through the OSHIN project, is that we have different line ministries, the health, agriculture, environment, forest and climate change, and also aligned ministries whose priority or the focus that we need to understand well while implementing the One Health, and the complexity need to be explored before any kind of implementation. Talking about the One Health system, the gross three complexity that we entertained, we come across during the implementation and we learned retrospectively is one is the clinical complexity, where we talked about either the zoonotic disease or the training of antimicrobial resistance and so on. The second complexity is, of course, the system complexities, that each and every health system has their own hardwares and the software, the core values. The third is the situational complexity. It's hugely contextualized the country like in India, and also applies to the other contextual regions across the nation. So the major focus was that we want to entertain with the human, animal, and environment from the perspective of One Health lens. But it, of course, with the support of 1 year implementation, it's not possible to entertain with all the building blocks of the health systems. So we only focused into the human resource component, how to strengthen the health system by developing the capacity. Although the hardware focus was to develop the capacity, we come across about the other soft values, the actors, powers, the content and the instruments and the institution, which I'll be reflecting short while through this project. So we had two major objectives. One, we want to develop, co-create the research workshops on prioritizing, because I said the clinical complexity is too wide in the One Health that we want to understand within the respective regions. Then we went the next step is the implementing the research and strengthening the capacity buildings. So we implemented in the three major Western Indian states. Just to give an overview, it's the Rajasthan, Gujarat, and Maharashtra. I sit in the Institute of Public Health, Gandhinagar in Gujarat. Two neighboring states, there was a rationale why to choose these states for this kind of implementation. So before entering to any kind of HSPR implementation, what we have done is, because the One Health field is still developing and more of rationales we are trying to build up, we conducted a 3 state level co-creative workshop where we adopted a participatory approach to bring all the ministry into one roof and come up with the priority for the respective setting. As a One Health scientist, it made us immensely helpful to understand what are the priority and what implementation or how the implementation should look like. Conducted a series of prioritization workshops in the form of 3 different state levels. Then we come into the implementation aspects of HSPR, where we clearly differentiated, because what was the real of the time is that community level workers and the clinicians are the two gross receiver of this kind of implementation. So when I talk about community, there are different community level workers, very contextual specific to the India-like country. We have people from health department, we have people from veterinary department, forest and wildlife, and other like agriculture, NGO, and all they are being in touch with the community and the households. Similarly, the clinicians, we have the medical officers, we have the veterinary officers. So a comprehensive modules like this were designed and respectively contextualized to the each and every states and formalized with support from the GLOHRA and the UKB partner in Germany, that we contributed to this field and conducted such kind of HSPR implementation aspects from the One Health. So what we have achieved with this partnership support from GLOHRA is that this One Health system strengthening project, with having the two prime objectives, so many of workers has been trained from the different sectors, and the knowledge was gained. So the ultimate impact that we would like to understand was how the preparedness can be strengthened. One of the colleague from the BMJ and also the WHO colleague will establish that how to work in that. And this could be the one example from the Western India, is that how to implement or apply the HSPR concepts from the One Health lens that we bring forward. So what was the learnings that assisted us to while going through this journey is that the system that we talk from the One Health perspective is too complex. It's nevertheless the non-linear. There are differential priorities that need to be understood before any kind of One Health implementation from the health system perspective, which is constantly changing. Pandemics are coming up. So, and there might be a differential interest and influence that might change the priority from time to time basis. So what important is document here is that from this kind of practical implementation is that the four things, what, which, who, and how is prior to implementing the any kind of One Health system strengthening programs. And of course, this will be more applicable to the policy applications and also to the another fields of either to the other applications of HSPR. Proud to share some of the key achievements that we received the copyright and different types of training materials, and so many of around 1,000+ One Health workforce were trained with this, the new concept of not only the One Health, but also scientifically, some of the contributions were successful so far. So with this, I must say great thanks to giving this opportunity on behalf of my the team. I would like to thank again for this practical learnings on HSPR from the One Health lens. Thank you very much.
Thank you so much, Sandal, and thank you really for showing us another sort of case study, different setting for where this has been applied and been applied to One Health setting. So again, a different topic. There are some questions now in the Q&A. Some have been answered already, but do keep typing your questions. I think, Kaivan, the first question here is to you, and it's a clarification question around the point you made that health policy and systems research allowed you to identify the intangible elements of response. I think this was a point in your findings slide. Perhaps could I ask you to reflect on that or elaborate further on the point?
Yes, sure. What I meant with this is that it allowed us to move beyond pure descriptives of only what has been done or looking only at the structures or at written policies, but look behind, the curtain in a sense, to better understand why our service delivery systems, for example, shaped the way we see them, or what is lying behind the relations of actors that are in the system working apparently maybe towards the common goal of providing a response, but then behind the curtains you realize a lot of other issues and tensions that then translate into performance challenges, etc. This is what I meant with the intangible elements that we cannot solely look at if we go out in a very kind of descriptive or structure focused and policy content focused way.
Thank you, Kumanan. Perhaps I can ask the other presenters to switch their cameras back on so we are visible now. There was a question, Kumanan had already answered this, but I'm going to put this a bit to the group, and especially also to Manuela and to Sandul as researchers around participatory forms of governance and whether they enhance health policy and systems regimes. In your experience, do you want to comment? Maybe Manuela, I go first to you. Participatory forms of governance, is that something that you've explored in the work on health financing, where you've done policy analysis?
I read the question and I have to say I wasn't sure what it meant for regimes. I didn't fully understand the question, if I may be very honest. So participatory forms of governance, it's a very interesting question, but I have to say I don't have a lot of experience with it. Unfortunately, the countries where I've worked do not really experience participatory forms of governance. I would like to say that I've experience with it, but unfortunately, the countries where I work do not really experience participatory forms of governance. I would like to say that I've experienced it, but I haven't. If I can really
fair enough. So no, it's good.
Rather the opposite. You know, like Burkina Faso, it's not exactly the best example. Pakistan, India, it's not exactly participatory forms of governance if we think at the high level, if we think more at, you know, like the bottom-up community level properly. And then I was not really understanding what they meant for health policy and systems regimes.
So
maybe, maybe.
Joanna, I mean, my answer in the text was, well, firstly, participation is a core value of our field, right? If you look in our alliance strategy, we say participation is one of our 4 core values, and we talk a lot about co-creation, and we talk about the importance that research is very important. But for our field, it's an applied field. So the inputs and the participation of communities, of policymakers, of implementers, of practitioners is very important. And that's one of the things we feel makes our field a bit different, right? And that's the way findings can be used in real time. They don't necessarily have to wait to be published in a journal, as useful as that is. But I wonder, maybe just, Manuela has raised some other dimensions. If you look at, say, a country like Thailand, which on the one hand has quite challenging politics, I think it's fair to say, but on the other hand has institutionalized participation in their health sector. They have something called the National Health Assembly, where civil society groups come together. It's a bit like the World Health Assembly. They bring private sector, they bring government, they bring practitioners, they bring community groups to talk about health issues and what should be going forward. And that's been going since 2008. But also Thailand is a country which is a real leader on health policy and systems research and funds it itself and really takes care to do health policy and systems research to inform policy development. So there would be an example where even if that participatory governance allied to health policy and systems research is contributing to health improvement. I think that in general, whether your system itself is participatory, and we're in an era when in many ways civil society space is being closed down in many countries, sadly. But all the more reason for us as health policy and system researchers and practitioners to think about how we enable participation in our work. But at the same time, it seems that in places where there is more participatory governance or participation in policy development, probably better able to use health policy and systems research.
Thank you, Kumanan. And I'm just gonna, there's one other question in the chat, but I'm just gonna ask Sandul about this because having listened to your talk just now, it seemed to me that your project was also very much focused on co-creation or co-creating the work you're doing. And do you want to reflect on that as an explicit aspect of the work on health policy and systems that you've undertaken?
Yeah, thanks, Devanshan. And I completely agree with the colleagues from WHO and that the soft values are quite important, because when we talk about this core participation, of course, the priority with the respective sectors are different, because the Human Health Ministry has their own priority, while contrasting to the Animal Husbandry or the Veterinary Ministry and the Forest and Wildlife. So what important is that from the implication at the community level, important is to understand the core values, and how to make them on board is probably the most important. And the second point I would highlight here is that the more components that we focus on the interest and influence of the stakeholders, because the priority is hugely driven by the kind of interest and the influence of, or the power, we could say. So that two component should be entertained before designing any kind of implementation if we are focusing on to the HPSR lens. That's my take. Thank you.
Thank you. And I think that reflects the integral part of thinking around participation really reflects this need to think about it from the beginning. And I think that's if I answer for the Alliance, that's I think what the Alliance seeks to address by saying participation is a core value of the field. Manuela, there's a specific question to you on the work in Pakistan I wanted to put to you in terms of the assessment of the ultra poor. How did you conduct these assessments, or what kind of study design did you pursue there? Can you comment on this briefly?
Sure. I think this goes in line with what Kumanan was commenting, and I think it goes about giving voice to people that traditionally don't really have voice. So what we actually did is that we had a quantitative assessment, so to really try and understand to what extent people's health needs are met among the ultra poor. So a household survey basically, so among the ultra poor, to try and understand in case of illness which proportion of the population was actually able to seek care and for which conditions, and then a very extensive qualitative assessment to try and understand why yes and why not people were seeking care under what conditions, following a very specific conceptual approach. And then we took together with the community this material to the policymakers to try and make it clear what were the problems and to what extent these problems needed to be integrated into policy. So very much try to promote participation, exactly like Kumana was trying to say before, as an essential value participation be. So it goes very much in this direction.
And very, very great care in the definition of the extreme poor. So there's a question now here by Harvey Joy asking around mobilizing resources, and in a way that moves us closer to our panel discussion. How can we mobilize more resources to support health policy and systems research? And he states that it's been supported by development partners and philanthropies, but to a lesser extent by research councils and science councils. Is it still not seen as a science, and should it be supported as such as that as well? Kumanan, I'm gonna put that to you, but then I'm also gonna ask Kaivan to comment from a German perspective.
No, I think it's a great question, and it's a fair observation. I mean, overall, since the 1990s, funding and investment in health policy and systems research has increased a lot, but still as a proportion of total health research spending, it's very low. And so I think, well, how do we change that? I mean, the first thing is to acknowledge that, clinical trials for new commodities are very important and will always attract a lot of attention, and often are sort of seen as the core business of science that people want to fund in health research. But I think, again, it's getting a greater understanding about the fact that I started my public health research career running vaccine clinical trials, right? But licensing the vaccine was only the first step. And without understanding how to deliver a vaccine, how to reach marginalized groups, understanding why people don't access services, you don't get the impact from that biomedical research. So seeing them as complementary and seeing them both as essential. And so we need to communicate that better. Some of the ways Manuela was saying before. It's great to have people like Lisa, not in a core research institution, but understanding and championing why this is an important field. I also think, though, we need to look at ourselves, right? And the incentives within academia are often around journal publication, impact factors, grant cycles, right? They're not things that necessarily motivate all funders to fund. Obviously, for research councils, that can be one criteria. But I do think that perhaps we should accept that we also need to go beyond research councils and think about seeing us as an applied science, as an essential tool, and we can get funding that way. And if you look at the countries that have increased their funding for this type of work, and it's not just high-income countries, it's the Chinas, the Mexicos, the Thailands, even in India, this funding for this type of work is increasing. They're doing that because they see it as essential for them to do evidence-based policy, to have effective policy, right? So we're showing impact of our work is very important. And one thing that we struggle sometimes with our jargon, sometimes our work isn't always easy for people to understand, well, why is this useful? What difference does it make? And I sometimes say, well, it doesn't matter if they call it health policy and systems research either, right? I mean, if they see it as research that's useful and they're willing to fund it. And so it's communication, diversifying the pool of funders. but also really thinking about impact and showing why it's useful.
Thank you, Kumaran. And just to ask Kaivan, as somebody because we are focusing a bit on Germany, or this is GLOHRA meets HPSR. What's your perspective from being based at a German institution, being a researcher in this ecosystem here?
Thank you. Just to second or to add on what Kumaran said, I can just answer on this question maybe from my experience on the topics we worked on. Because, for example, in the pandemic, one observation was that actually the calls for projects that were related to health policy and systems research came quite late. So it made the impression our team and other colleagues had very early on, who were interested in these fields, very early on also proposals set in a phase where a lot of the focus has been on, you know, biomedical solutions and biomedical issues, but it appeared like we need health policy and systems research only when a crisis is over, you know, like then afterwards looking into your records and reading the books. But that's not how it works, right? So we need this type of lenses and approaches for the issue of timeliness, especially in the context of crises, but also beyond. And the other experience regarding the timeliness that we made, especially in the migration focus, is that actually we barely are successful. So my team and I, this may be a surprise to some colleagues, that we are barely successful in migration-related calls for research because they are very siloed. You know, they ask us for a specific target group and diseases we focus on or conditions. But when you want to come up with a proper approach for a health system, a policy perspective, you would say, you know, I'm looking at continuity of care, or I'm looking at a quality of care in a given domain, and I consider a diversity that a system deals with. And not all calls really can deal with this broad approach. So where we are successful is more in the specific domains that go into the area of health systems or structures or health services research. So we definitely need more funding calls in this respect. I would say that really consider that you approach a health challenge or problem from a systemic perspective, where you of course need to break things down into manageable parts and data collection, etc., but where you do not necessarily always confine yourself to specific diseases or conditions.
Interesting. And I'm gonna slowly move us into the panel discussion, but trying to answer the questions that we have here in the chat as well. So I'm going to go to Lisa actually with a question by somebody anonymously typed into the chat, and I'm going to combine that and ask you. So the question in the chat says, should we focus more on priority setting research for resource allocation? So a health technology assessment, the kind of stuff where you can say, okay, we can have some sort of prioritization in our health systems investment. Or I think you've actually, Lisa, made a very strong case for health policy and systems research and the insights you see. So maybe as a second part to your question, can I ask you a bit from not putting you on the spot too much, but from the perspective of a ministry who really uses that kind of research, what do you think you could do to support the building of this field in the dialogue? So in a way, a two-part question. What around priority setting research, how important is that to you? And then thinking around HPSR, what can your ministry do to support the building of this field in Germany a little bit?
Yeah, thank you for those questions. So maybe I start with the first one, more on priority setting or more on a systematic approach. I mean, I would tend to say it's no either or, right? I guess both are necessary and needed. And on the one hand, we also must understand how very specific, for example, technologies work. But then also we need to make the connection how they work to improve the system, which is then more the systematic approach. So I don't even know if it's really possible to kind of split those approaches. So I think it's important to have research on the very specific topics, technologies, data collections, and so on. But then it's also important to have other research that then takes those specific inputs, so to say, and tries to apply that to the more systematic approach and to see impact, where we can make most impact, where also, I mean, of course, it's a ministry, right? So unfortunately, we do not have unlimited resources. In fact, it's a very constrained environment. So what is interesting for us is also to know how to spend money wisely in a way, right? So where can we, with very limited resources, create impact? How are value for money considerations working, and so on? So, I mean, this is no clear-cut answer, but I would still say it requires both, and both are of course needed. And I would probably tend to say that from a policymaker perspective, just like due to also time constraints, right? And it's of course great to have overview studies as well, where we can understand where we should act and what makes most sense and where we see most impact. And then maybe coming to where we could kind of like support you more. And there that would also actually be a question for you, right? What would you actually wish for? This is also then something that I can think about, whether we can do that or not. I mean, not everything will work, as we have unfortunately limited time and resources, but other things can work. And I think a webinar like this today is a start, right? And we can try to actually engage more via email, organize maybe something together, exchange. Also see, I told you before that we are also part of Global Health Initiatives, where we are, for example, in the board of the Global Fund and Gavi. This could probably also be interesting for you to know, right? So when you have something where you feel we should actually know that, and we should also push for the topics and for the research more, then this is something we could try to do. And I mean, I'm always trying to actually push for more evaluations and more science-based decision making anyway, which is probably also due to my former role as a researcher before joining the ministry, but really also open to hear your ideas. And then we can, so please feel free to reach out, and then we can think about what to do.
Fantastic. So I think thank you. Well, really, thank you for that invitation. I'm sure we'll take it up as GLOHRA members, but also as community more widely. So Sandul, I'm gonna move to you, and I'm gonna ask you a bit based on your experiences of using health policy systems research in India. What's your experience? What would be your advice for Germany, for us as researchers, on what are the lessons you think introducing this here, using the research here? Kaivan is reflected a little bit. He said not the sort of, you need more designated funding codes essentially, but in terms of practically implementing this type of research, what are some of the key lessons you'd like to give us?
Yeah, thanks, Joanna, and for asking me much bit of more difficult questions. But yeah, it's good to say that from the experience of HPSR implementation in the One Health perspective, what could be the takeaway, or that at least we have learned, is that before entering to any kind of HPSR, it's not that we don't have much funding to it, but whatever the funding you get on the HPSR is wisely need to be kind of anticipated in the form of implementation. So the first thing, understand your system, explore your system, know the context very well. So that might help you design a robust implementation plan. The second thing is more talking about the priority. It is always important, because to me, the One Health field is quite wide. Either we should focus on the zoonosis or we focus on the AMR. So the challenges, the issues, the burdens are wide and variety. So to understand the multidisciplinary aspect, or the moreover the transdisciplinary approach to any burden for the priority. The third and the last point for me to the learning from this implementation is that only the hardware or the core functioning of the health system is not only important, but also we should understand the core values, the soft values of the system. So probably these three will be the takeaway from the implementing the One Health in the country like India, which has the vast diversity and the system is too complex. Because I always emphasize on the systems approach, and to understand the complexity is more valued rather than Of course, the evaluation and the assessment is quite helpful for the policy actions and the decision makings, but understanding the core values of any functions and taking into the level of policy is also equally important and need to be prioritized. Probably the researchers or the academic scientists like us will be more beneficial of exploring this way of HPSR. So thank you very much.
Thank you, Sandra. Some really good lessons there. I'm gonna ask Manuela to comment now. So you've worked with different actors and funders here. You've worked with the Alliance. You've worked with the BMZ. Could you reflect on that research and policy interface? And there is a question in the chat which asks, before moving to the intervention, do we need to involve government policymakers into the research? So I think that, in a way, I wonder whether you could comment on that as part of your answer. And then I do want to put a bit Lisa's invitation to you already. So as an HPSR researcher in Germany, if there's anything you do want to put at her door already, do make use of the opportunity right now. So over to you, Manuel.
So maybe a word on my history. I started as a doctoral student working on a trial, but actually a health system trial. I did my postdoc on a second health system trial, and then I decided that I liked it better to work with interventions that were already in place. So I said that I would do intervention research if really needed, but that actually I prefer to meet the policymakers where the policymakers are. So I think that's also part of a choice that one makes. And it's a little bit of a risky choice because it means that you spend a lot of time in this policy engagement and maybe a little bit less time writing papers, but it's a choice that one has to make and one has to be true to their heart. So I think if one decides to do that, one has to be ready to spend really a lot of time in that policy engagement. So one has to really spend a lot of time talking to all different levels of stakeholders. So policy practitioners, implementers, the consultants that come in the game. Where I personally feel we're still lacking is really in talking with communities. This is where I personally feel we are lacking in creating the full dialogue. So we're talking a lot of co-creation. I gave the example before of this needs assessment, but I feel that bringing everybody around the same table is still difficult. So I feel as researchers, we talk to everybody and we try to do our best to really give everybody a voice maybe, but then really making sure that everybody sits at the same table is maybe not just the responsibility of the researcher, it's everybody's responsibility. And maybe that's where this community as a whole needs to be doing the next step, all of us together. And one thing that Kumanan rightfully said at the beginning, the incentives are not set right. The incentives in academia are definitely set towards writing papers and teaching, maybe. I want to say maybe, and not towards necessarily writing policy briefs. But for example, in the project that we have in Pakistan, when we selected the young researchers to work with us, we said it from the beginning, this is, you will write papers, you will write top papers, but you also have to do a lot of policy engagement. And there is a self-selection. People chose to work in that project who want to do that kind of work. So, yeah. I want to say to people like Lisa, keep investing in this field because I think we have both to gain. And I think we can try to bring everybody on the same table.
Thank you. Thank you, Manuela, for that. And also interesting what you say about the self-selection, right? About the type of people who are interested in doing health policy and systems research. Kaivan, I'm gonna come to you and I'm gonna ask you again about the topic of research. So it's interesting. It was interesting to me. You reflected on uncertainty as your meta theme in the presentation today. I have to confess, I associate you quite strongly with migration as a theme. And I wanted to ask you, because in GLOHRA, I think many of the people who are here in the webinar and who will listen to this are in a way developing as researchers, and they're looking to what method do I use. So in a way, you have addressed this a bit, speaking about uncertainty, but if somebody thinks about the research topic, so what should I look for if I want to become a health policy and systems researcher? Are there particular things you think lend themselves, or what would your advice be on this?
Thank you. I would say, as always in science, the question of how to approach things, and it is depending on the research question, right? So I think it's not necessarily a topic, but it's a question that is underway that would lend young researchers to using or embedding their own works into the health policy and systems research field. And I think it's important to say, and to link to what Kumanan said, it's not a single method that is out there. It's also not a single way that is correct or wrong, but it's applying it's kind of taking a position, taking a perspective, blending methods as appropriate to answer your question. And this question obviously is most often one that is not closed, it's open. It's when we want to understand how different things work, not only if they work, but why and how, and where are the issues of the problems that are maybe not obvious or easily graspable into quantitative or conventional epidemiological approaches, and then you're entering step by step actually this field. And I think these are the elements that make a topic suitable for health systems and policy research. And then obviously, or not obviously, but in my experience, it's actually the scientific part of taking pieces of puzzles to give you the bigger picture. And I'm not talking of the whole picture, but the bigger picture and the links between different elements. Because in science, we need to, and this links maybe to the presentation of Sandul, which I liked, we have the complexity out there, but in science, unless we do complexity science, we are always a bit reductionist, and we need to simplify things and take the single elements out to then give you, the links and the bigger picture of how maybe systems operate and lead to certain outcomes. And I think this is something where young scientists often struggle, because then they say, okay, but now I have done an interview study. How does that now? Why is this now health policy and systems research? But I think it's then the combination of multiple single studies that give you a bigger picture and lead you to lend towards that field.
Yeah, thank you. Fantastic. Very concrete advice. So define your question. I think that's a very, very important aspect. Find the question, define the question, and that's really what is the entry point to the methods that follow. Kumanan, I've gone full circle back to you. So the Alliance, you've built this field, right? And you support explicitly the Alliance supports explicitly the application of health policy and systems research in countries at country level. What's your advice to us, GLOHRA, in Germany? What would you say? You got a bit of a feel, I think, for us now after today. What's your advice to us?
Well, thanks so much, Joanna, and thanks again to GLOHRA and all the panelists. It's just been such a wonderful discussion. And I mean, maybe three things. I mean, well, maybe there'll be four. Firstly, I've been coming to Germany for almost 20 years. And Germany's role in global health and health policy and systems research is very different today than it was 20 years ago. 20 years ago, we didn't have GLOHRA. 20 years ago, you didn't have a hub a WHO hub in Kreuzberg in Berlin. I never thought I would see that. 20 years ago, Germany was always a big contributor in global health, but didn't have such a presence. You didn't have the World Health Summit. You didn't have a GIZ hub. So Germany is a real center now, as it should be, the biggest economy in Europe, so much to contribute. So it has a real presence in global health now, and that's great. And we like coming to Germany. We would love to see more health policy and systems research from Germany being shared with the world. We have strong institutions, and it's great. We know Manuela, we know Kaivan, we know you, Joanna, we know Tori, we know a number of colleagues in Germany, but we'd love to see more. We'd love to see more health policy and systems research from Germany, whether that's on Germany itself, but that's also Germany engaging with the world. And you've had, I'm not sure if Lisa will come back to one of these webinars, she's going to be besieged by responses to her invitation to do more. I'm really thrilled to hear that. So you have champions and funders, right? So we would love to see the German footprint on health policy and systems research perhaps increase in the same way that the German footprint in global health overall has increased. Right? So, and you have great people as on this call and others who can lead on that. So please take advantage of that. I think that we would really love to see GLOHRA continue. It's such a great initiative, and you know, Nora, Leah, and others work so hard. Better, it's a great initiative to continue network, and we would love to continue to collaborate with GLOHRA around how what is useful, bringing some of our experience, but also learning more from what's happening in Germany. You know, Joanna, we've talked. The Global Symposium is in Nagasaki this year, and we hope to see many of you. Perhaps one day soon we will see a global symposium or a similar sort of global meeting on health systems research in Germany. I think the final thing I would like to sort of say is, again, you know, define your question absolutely. Think about the communication. You know, Manuela, you said rightly that often the attention goes to writing the paper and not writing the policy brief. But perhaps with the technology here, this is my point on the digitalization, you can ask ChatGPT to write your policy brief, right? And really the technology is increasing so fast and it has dangers, but it shouldn't be an either or, and that should allow greater diversity of communication. You should be able to package not just a policy brief, you should be able to write a specific communication for your audience and tailor it. And it shouldn't be either or. I think that's really going to be a reality if it's not already very soon. And then I think that final point is that research has to be used. And I completely agree with Manuela on the communities, right? And that is something that I think we could do better. Some of you might have seen that Richard Horton wrote an offline about Japan's public health nurses in the last couple of weeks, which was from a conversation that was in a side event that we hosted at the World Health Assembly, where one of the assistant minister from Japan said, well, the paradox between Japan's very high level of health outcomes and not so strong health systems research, and that was his own words, was the role of public health nurses and their interactions with the community and being able to collect information and feed information into policy and implementation decisions alongside communities. So we shouldn't see community involvement just as a nice to do. We should see it as something that's essential to the success of our research and our learning, but even more so to the success of our policies and programmings. And you know, Germany also is a country with high levels of civil society involvement and community involvement. So maybe there are some lessons there that Germany can share as well. So thanks again. And it's just been such a pleasure to be part of this.
So fantastic, Kumaran, fantastic for those for that wonderful roundup. And I think from my side, I can just say a very, very big thank you to all the presenters. A very big thank you to the audience who contributed. So my sense of this, and we will post a recording of this webinar online, I believe, on the GLOHRA website. My sense is there's a field of health policy and systems research that has much to contribute, that, as Kumaran has said, has come quite far also in Germany, but can go further, and where GLOHRA is really a key. The development of GLOHRA in the next 5 years, I see health policy and systems research as one of the core disciplines within it. And I think despite all the advantages or all the advances we've seen, health policy and systems research is still a sort of underfunded discipline within the area of global health. I think we've heard a lot, I think, today, and Kumaran, that echoes your last point around participation and how central that is, right? And the co-creation with communities to the method itself, but also to achieving the impact that we've heard. And I think the last and perhaps biggest thing for me I take away from today's webinar is really how many allies we have in Germany. So Lisa, thank you for the invitation. I think there's much that Germany can contribute in the multilateral space, pushing for this type of research. I also think it would be fantastic if Germany was to host the Symposium for Health Policy and Systems Research either in 2 years or in 4 years' time. I think it would bring the community together. I think it would be a relatively small investment to create high visibility and really do a leapfrog in that field here. And Lisa, I'll come knocking on your door at the BMZ. I knock at the door of my ministry at the BMG, and GLOHRA, I don't need to knock on your door. I feel I'm part of your DNA. So I think we've got some very concrete steps to go. I hope we've inspired some of the researchers on this call to continue with this method. I think everyone here is a mentor to everyone in this virtual space. And again, thank you for the opportunity to discuss this with you. So I'm going to say bye-bye from Berlin and have a good rest of your day.